So I'm going to talk about the pathology of these disorders, and I'm going to focus on these four, PCAN, MPAN, BPAN, and PLAN, with a comparison to common older onset neurodegenerative diseases, in particular Alzheimer's and Parkinson's disease, and then make some comments about that. I'm going to start with PCAN because the features of PCAN are present in all the as well, especially those of featuring the effects on the basal ganglia, the globus pallidus in particular. And those are iron accumulation. But I really want to focus on another lesion that we've described in recent years, and that's this. This gives the appearance of that lesion. You see, there's some iron. That's the brown pigment in the background, but there's also these structures, these granular structures that we identified as neurons with some effort. And we've determined that this does appear to be the hallmark lesion of PCAN in the globus pallidus, and that these are neurons. They're basically completely degenerated, and they contain a large amount of ApoE, and we determined also that some of that ApoE is ubiquitinated. So that hallmark feature, as we looked around, we found it in other brain disorders as well, most notably in strokes or chronic ischemic disease that affect several regions of the brain, but the globus pallidus in particular. But so this PCAN neuron, as we call it, the ApoE positive neuron, is a hallmark of PCAN and these other disorders. So we have this hypothesis that ApoE expression in neurons is not a normal event. Astrocytes make lots of ApoE, but neurons don't normally do that. But there are certain neuron populations in particular, and especially those in the globus pallidus, which express ApoE under conditions of sustained stress. And that ApoE can become ubiquitinated over time. And this appears to be fairly novel. Even as these neurons degenerate, they're not cleared from the globus pallidus. I think there are some peculiarities of that brain tissue that make it resistant to that type of turnover, but they persist as these mummified PCAN neurons. Okay, so that having been described, I want to move on to these other disorders and describe the additional features beyond the PCAN baseline that we see. And much of the rest of the talk is going to focus on MPAN because I think that's informative with regard to other common neurodegenerative diseases as well. So what is MPAN? I say PCAN plus Lewy body disease, where by Lewy body disease I mean Parkinson's disease, with additional spread to the neocortex. And I put an asterisk behind that because it's not quite the same, because in Lewy body disease involving the cortex, almost invariably you find quite a bit of beta amyloid in the cortex, and in MPAN you don't, and in fact in any of the NBIAs, beta amyloid is generally not seen. So so it's not quite the same. So that's the nature of the asterisk. So this is what the globus pallidus looks like in MPAN, and it looks very similar to that in PCAN. You have these granular structures, then here's iron pigment in the background. And again, this is not a very clear stain. The lighter brown here is an immunostain detecting ApoE. So these are ApoE and ubiquitin positive neurons. They're the same as PCAN neurons, those degenerating neurons that you see in PCAN. In addition, there's massive neuronal loss in the midbrain, which is a tip-off to the other really striking feature of MPAN, and that is alpha-synucleinopathy, the Lewy bodies. And here, these are in the midbrain. This is very obviously a Lewy body in a midbrain neuron. And these Lewy bodies are abundant, and they're abundant throughout the brain. This is the neocortex with an immunostain for alpha-synuclein. And this is many times more neocortical Lewy bodies than you see in sporadic Lewy body dementia. So alpha-synuclein appears to be the other hallmark protein along with the ApoE positive neurons of PCAN. So BPAN is the next disease I want to talk about. And as a shorthand, I think of that as PCAN, in other words, PCAN neurons plus changes of Alzheimer's disease. And again, there's an asterisk there implying that amyloid is again missing from the picture. So again, these are the ApoE positive neurons in the Globus Pallidus in this disorder. And then in addition, you see a large burden of neurofibrillary tangles and tau-positive dystrophic neurites in the hippocampus and elsewhere in the brain. And these look very similar to both the precursor lesions and the full-blown lesions of Alzheimer's disease. This picture over here, this is a tau immunostaining, shows that you see some precursor, almost not quite pretangles, or a little bit more than pretangles actually here, with some aggregation of tau in the neuron, cytoplasm of this neuron, and then a full-blown tangle right here. Interestingly, in BPAN, I think ubiquitination of these lesions occurs, I think, relatively slowly over time. This is a hallmark of extended chronicity of these diseases, of disease where you find it. And you see that in PCAN, in those PCAN neurons, but you don't see ubiquitination of tau in BPAN. And I think that's because this disease is, or at least you don't see widespread ubiquitination. I think this disease is more aggressive, and the chronicity is not sufficient to develop that heavy ubiquitination that you see in Alzheimer's disease. The disease is very severe. So this is showing some of the effects on the cortex, very heavily damaged cortex. And there is some ubiquitination that occurs here. Actually, I think these two images are flipped. So the tauopathy is more significant than the ubiquitination. So I want to move on to PLAN, which has features of the PCAN neurons. In addition to that, the tauopathy of Alzheimer's disease plus Lewy body disease, alpha-synucleinopathy of Lewy body disease. So again, this is the Globus Pallidus showing iron accumulation, and then these PCAN neurons, these large degenerating structures. And then this is the hippocampus. Now, the hippocampus is an informative structure because it's damaged in different regions in different diseases. It's especially susceptible to injury in the CA1 sector in Alzheimer's disease, and more susceptible to the CA2 in Lewy body disease. And here you see both sectors are heavily affected. There's a lot of neuronal loss in both areas, pointing to both tauopathy and synucleinopathy in this disease. And in fact, you see all the features of Alzheimer's disease with tangles, including ghost tangles, and here's granulovacular degeneration. So this really does recapitulate all the pathology of Alzheimer's disease. And then in addition to that, you see a large amount of Lewy bodies and Lewy body in the cortex in the midbrain, as you find in advanced Lewy body disease. So I want to, so much for review. I want to get on to the subject of what the NBIAs tell us about more common age-related neurodegenerative diseases such as Alzheimer's, Parkinson's, and Lewy body disease. So we've done additional work on this, and morphologically, the tangles and Lewy bodies that you see are quite similar to, in the NBIAs, are quite similar to those of age-related dementias. And we found also that, I didn't show any of this data, but they're biochemically similar. There's a host of antibodies that you can use to different phosphoepitopes, for example, of alpha-synuclein. And it's pretty much the same epitopes in the NBIAs that are detected as in sporadic Lewy body disease. So there appears to be fairly, at least some aspects of the biochemistry of these lesions are fairly consistent in both rare and common forms of these diseases. In Lewy body disease and Alzheimer's disease, beta amyloid plaques are commonly found, and we believe that they're early inducers and potentiators of pathology. But we don't see this in NBIAs, which suggests that the NBIAs functionally produce shortcuts to these pathologies without the prolonged amyloid phase that other genetic evidence suggests is important for these other age-related diseases. And I think this is an opportunity to get some insight into tauopathy and synucleinopathy in relatively isolated forms in the aging brain. So as I mentioned before, Lewy body dementia features widespread Lewy bodies, including in the cortex, and most often intermediate stage tangles, but the relationship between these is unclear with advancing age. It's complicated by the fact that you have beta amyloid associated with both Lewy bodies and tangles. So if you remove beta amyloid from the mix, let's look at what we see. So I just took Mpan as an example, and I have 4 cases of Mpan here, and I stained up the cortex, frontal lobe, frontal cortex, with both alpha-synuclein and tau. And I arranged them here, the 4 cases from left to right, with increasing pathology. And I didn't talk about the co-pathology of tauopathy and Mpan because it is in most cases much less than that of synuclein. But in severe disease, for example, in this last case, you can see significant tauopathy, which is roughly in proportion to the amount of synucleinopathy. So one can interpret this in 2 different ways. And so first of all, do Lewy bodies induce tangles through a specific shared mechanism? That's one possibility for this correlation. Or is it more that Lewy bodies produce brain injury and that tauopathy is a non-specific response? And that's actually a valid thing to consider, because tauopathy is not unique to Alzheimer's disease. You find it in quite a few diseases, including trauma. So we know that. And in the vicinity of localized lesions such as brain tumors occasionally. So there are more roads to tauopathy than amyloid. We know that already. And perhaps this is an example of this. So one can look again at the hippocampus, which is variably susceptible to injury due to tauopathy, as I mentioned before. That's the CA1 sector, versus nucleinopathy in CA2. And we can look at that in Mpan and just try to determine, are tangles found more in association with Lewy bodies or in association with local brain injury? So looking at, I just took here the 2 most, the least affected case and the most affected case. I'm sorry, I want to go back. Okay, I pasted the wrong image in here. I apologize for that. But I'll tell you the result though. And that is, with advancing severity, the tauopathy is apparent in the tauopathy susceptible brain regions, even when synucleinopathy is mild or absent. That is to say, with severe synucleinopathy in Mpan, you see a lot of tangles in the CA1 sector of the hippocampus, and not a proportional number in the CA2 sector. So the tauopathy appears to track according to the susceptibility of the hippocampus to the disease associated with that molecule, rather than tracking along with just the degree of synucleinopathy. And you can see that especially in the granular neuron layer, which is quite susceptible to tauopathy in Alzheimer's disease, but not at all susceptible to synucleinopathy. And you see tangles in the granular neurons in Mpan that you don't see, Lewy bodies there. So that implies that tauopathy is a response to synucleinopathy and associated brain injury rather than synucleinopathy itself. Okay, to summarize, lesions of NBIAs recapitulate those of the more common advancing age-related neurodegenerative diseases, and mutations in the NBIAs surely can provide insight into the pathogenic mechanisms of older disease. Some reduction in the complexity of NBIAs, that is to say, there's no amyloid in them, facilitate the disentanglement, pun intended, of lesion pathogenesis in complex older diseases. And finally, I would like to include these final thoughts. It seems to me that surely the similarities of pathologies of the NBIA in more common sporadic disease warrant more general sponsorship of NBIA. I think that this might be a mechanism to increase interest in rare diseases if the parallels to common diseases can be pointed out. And also I'd like to suggest that the treatments that are found to be effective in NBIA may have relevance to treatments that might work in more common sporadic diseases. So I see I'm right at time. Thanks to all my collaborators, you know who they are, and I'm glad to take questions. Thank you.
Thank you, Andy. And I guess it is a very interesting talk because you clearly show that the NBIA in general, maybe in particular with Mpan, represent a perfect example of how rare diseases, just as NBIA, can help for understanding the pathogenic mechanism of common disease and how it is important to continue to work on these very rare diseases. So now this talk is open for discussion. There is one question, first one question from Odysseus, which is, do you see comparable phenotypes in the various mouse models?
No. Not that I've seen so far.
You mean you didn't see or you didn't look at?
Well, so depends what you mean. The pecan mouse model doesn't really show this. I haven't seen any more complicated models where there's been an attempt to mix these pathologies. As a matter of fact, those models are rare, are only starting to be developed in the more common age-related diseases. So we don't have a lot of experience with attempting to mix models yet.
Okay. There is another question from Dr. Ortiz Gonzalez. For the Mpan, did the variability of disease correlate with patients' age?
I don't know offhand. It correlates with disease severity. So clinical phenotype severity, which is, I think, the key thing. And that can vary with age, but there's a lot of other factors in that too. For example, the nature of the support that a person received while they were alive. A person can receive this with age-related diseases as well. A person can survive for a long time with severe impairments if the support network is very good, and that produces a tremendous amount of atrophy at autopsy. So that's a complicated issue.
Okay, thank you. So there is no more questions, and as we are perfectly on time, we should stop now this session.